I started out actually in the ICU in the cardiac intensive care unit, and by virtue of seeing a lot of patients with cardiac arrhythmias, I became interested in electrophysiology and had the good fortune of being recruited to our electrophysiology subspecialty and kind of evolved there as a nurse practitioner. I really think now many more people, even though it is the most common clinical arrhythmia that we see, more people are aware of atrial fibrillation. Patients, families are aware, but also not only cardiologists, but other primary care physicians and practitioners are also aware of atrial fibrillation and adverse cardiac outcomes. Well, I think patients, when they have symptoms, they might think about atrial fibrillation. So they may have their heart failure, but then they'll say, wait a minute, maybe that shortness of breath is something else, and they'll contact their healthcare provider, maybe come in, get a cardiac electrocardiogram to see what's going on. So it varies. Some people can be completely asymptomatic and just fatigued or tired and not just quite feeling like themselves. Other people will have pronounced palpitation, shortness of breath, things like that that can be associated with atrial fibrillation. I think each patient is unique and they have their own set of symptoms, but they recognize sometimes something just isn't quite right. So it kind of depends on, we look at different things, their CHAD score, their CHAD-VAS score. The clinical guidelines, of course, guide us into whether or not we might start anticoagulation. Obviously, we want to prevent adverse outcomes such as stroke, worsening heart failures, a big concern, and of course, their quality of life. It really depends. Some patients are doing fine on warfarin. They've been on it for many years. They have a stable INR, and that might be just fine for them. Other folks are on these novel agents, novel oral anticoagulants, and that's working well for them. They have an active lifestyle. They may not want to get their levels checked every month or every couple of weeks. So it really depends. It's a provider decision and looking at the total patient and their profile and risk factors. I think we utilize them certainly when there's a bleeding situation, and they seem to be effective for reversal when needed. So, we as practitioners are aware of those reversal agents and certainly employ them when we need them in a surgical setting or someone who might present to the emergency room, for example, or places we would use that. I think actually any practitioner or the patient themselves can actually diagnose atrial fibrillation if they're able to take their pulse and they feel that their pulse is irregular. Of course, EKG confirmation is what we look for, but just kind of walking someone through a telephone call where you can really kind of hone in on some things and then referring them for an EKG or a telemetry strip so you can see what that particular rhythm is. So patients are smart. They know how to take their pulse or kind of figure out when things aren't quite their normal. I think everyone can treat the condition. I think it's a really team-based approach. So you have, primary care practitioners who are managing a series of patients with atrial fibrillation, nurse practitioners, physician's assistants, certainly cardiac electrophysiologists who perform a lot of procedures are managing big patient populations with this arrhythmia. I think probably one of the biggest challenges is the patients don't realize a lot of the cardiovascular risk factors that kind of lead to atrial fibrillation, which are modifiable. So sleep apnea, weight loss, all the things that kind of keeping their heart failure in check, watching their sodium, all those types of things that can kind of be managed really well and kind of maybe make someone feel better or have less paroxysmal atrial fibrillation episodes. I think we'll probably have more self-management centers. We'll have more technology, obviously, self-monitoring, the iPhone, some of those applications, a lot more direct, immediate contact, the patient with the practitioner. Maybe a pill in the pocket is something that one patient might benefit from, or an increased dose of their beta blocker. Things like that I think we'll see more of. Well, certainly manageable. I mean, ablation is one therapy. However, some ablation procedures require a second or third to really be effective. And, we always aim for improving the quality of life of the patient. So that might involve a cardioversion for one individual, medication for somebody else, an ablation for somebody else. So different treatment options or combinations of those treatment options. Well, I think stopaf.org is great because it's a forum for patients to connect with other patients like themselves who have atrial fibrillation. It's a place where they get accurate medical information and resources, as well as that they can have a conversation or a dialogue with other people regarding symptoms, management, questions. So it's a reliable website for them to go to and engage. I think some of the patients do, there's a variety of things they do that may not be, with reliable medical sources. So, when you have stopaf.org where they have the latest science, it's been published, it's been peer reviewed, versus maybe a patient just hearing something from a neighbor or family friend who, it may not be based on anything per se. So. Well, I think a lot of people don't actually understand where it is in the heart, the type of arrhythmia that it is. Sometimes people get confused with a ventricular arrhythmia versus an atrial arrhythmia. And I think some individuals don't really realize the potential impact of it, that it can lead to stroke, if untreated, and things like that are, I think, a lot of the still need clarity for some patient families.